Welcome to Clinical Minute. Female sexual health, hypoactive sexual desire disorder, referral to a specialist. Jen is a 24-year-old graduate student. Prior to her well-woman visit, she completes a pre-visit screening questionnaire about satisfaction with sexual health. She indicates on the form that her interest in sex has been negligible for the last year. In your office, during your history and review of systems, she tells you that it was one of the reasons an important relationship ended 6 months ago, and that she feels both frustrated and sad about the situation. You probe Jen about what she meant by negligible, while educating her about desire versus sexual activity. You ask, do you have any interest in being sexual? Do you ever have spontaneous erotic thoughts or fantasies? You tell her that the idea of wanting to have sex, regardless of whether one acts on that, is desire, like having an appetite whether or not you consume food. She tells you she has no appetite for sex. You ask if she ever had desire. She says she did in her early teens, but has not for many years. You ask if she is distressed by this, and she tells you that she is. You ask, can you experience arousal, meaning lubrication and sensation, when you do engage in sex? She says yes. You ask if she can reach orgasm. She says she can on her own, but not with a partner. You ask about whether she has any pain with sex, and she says no. Based on her report, you suspect she has hypoactive sexual desire disorder, but will probe a bit further to consider etiology. According to the World Health Organization, sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. For sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. In 2016, the International Society for the Study of Women's Sexual Health agreed on nomenclature for female sexual dysfunctions. This is the nomenclature used in your clinic, although you are aware that it differs slightly from that in the DSM-IVTR. HSDD may be primary or secondary to another condition, lifelong or acquired, and generalized or situational. Criteria for diagnosis require the presence of either lack of motivation for sexual activity or loss of desire to initiate or participate in sexual activity, along with clinically significant personal distress. This distress can take the form of frustration, grief, a sense of incompetence, loss, sadness, sorrow, or worry. The symptoms must represent a change from the previous state that has persisted for at least 3 months. The prevalence of female sexual dysfunctions was assessed in the PRESIDE study. This cross-sectional, population-based survey assessed more than 31,000 women in the United States who were at least 18 years of age. The survey found a prevalence of low desire in 38%, with 10% indicating low desire associated with distress. Low sexual desire has been associated with several adverse outcomes, including lower health-related quality of life, dissatisfaction with sex life, partner, or marriage, negative emotional states, including frustration, hopelessness, anger, poor self-esteem, and loss of femininity, as well as divorce and resulting lower socioeconomic status. Several psychological conditions and issues can contribute to HSDD. These include mood disorders or states such as depression, irritability, rage, fear, shame, and embarrassment, anxiety or lack of sexual self-confidence, sleep disturbances which can decrease psychological resilience, developmental issues from the past, such as trauma, abuse, the impact of childhood illness or surgery, divorce, affairs, abandonment, or other experiences resulting in a lack of trust, and body image issues. Interpersonal issues can also contribute to HSDD. Some of these include chronic discord in the form of emotional estrangement or disappointment, ghosts of past relationships, which can lead to fear of making oneself vulnerable or negative expectations, partner sexual problems, such as erectile dysfunction, rapid ejaculation, low or discrepant desire, or being sexually maladroit, and partner psychiatric illness, such as addiction or depression. Because a variety of general health and psychosocial factors can impact sexual function, a thorough sexual history must cover a lot of ground and must include both medical and psychosocial issues. Questions about medical issues should explore the items listed on the left. Questions about psychosocial issues should explore the items listed on the right. The PLICIT model can be a helpful tool for discussing sexual health or concerns with patients, and for planning next steps for screening and management. The model consists of 4 components. 1. Permission. Ask open-ended questions during the routine history to give the patient permission to talk about her sexual concerns and reassure her that her feelings are normal and acceptable. You could say, "Many women with menopause have sexual concerns. Do you?" Then use follow-up questions such as, "What do you mean by that?" or "Tell me more." 2. Provide limited information. Provide education about female pelvic anatomy, the sexual response cycle, and the neurobiologic etiology of sexual problems. Discuss changes in sexual function throughout the life cycle. Explain that sexual interest or desire may not be the first stage in response, and explain that women may not experience orgasm 100% of the time. There are many topics to cover here. Address the most important ones in the time available, but don't feel pressured to cover all in one visit. Ask the patient to make a follow-up appointment to focus on sexual health concerns. 3. Specific suggestions. Offer specific suggestions and solutions to treat the problem. For example, suggest the use of lubricant, over-the-counter moisturizers, or topical estrogen for dryness or dyspareunia. Suggest that she plan date nights and make sexual activity a priority. Suggest that she improve her diet, exercise routine, and sleep patterns to help overall mood. 4. Intensive therapy. Consider referring the patient for intensive therapy to qualified sexuality specialists. Here's a suggested general approach to treating sexual concerns. Use the PLICIT model for history taking and for first steps in management. Facilitate patient and partner education. Identify and treat medical conditions that may contribute. Consider medication and substance use, both current and past, as playing a possible causative role and resolve appropriately. Recommend therapies as appropriate. And provide or refer for sexual counseling, coaching, and intensive sex therapy when indicated. When a sexual concern exceeds a clinician's level of comfort or expertise or warrants intensive therapy, a referral to a qualified specialist is recommended. Many patients can benefit from psychotherapy and sex therapy. Psychotherapy may be in the individual, marital, couples, or group setting. Strategies include cognitive behavioral therapy and mindfulness-based therapy. Sex therapy or counseling may be for individuals or the couple. Strategies may include education, sensate focus therapy, which helps individuals and couples desensitize to sexual activity that causes anxiety or avoidance and increase non-demanding pleasure, and counseling for past sexual abuse or sexual trauma. Mindfulness has been incorporated into a brief psychoeducational treatment program for women with sexual desire and arousal disorders, and found to be effective as part of a larger treatment program. In studies, women qualitatively reported that the mindfulness component was the most valuable aspect of treatment. Significant improvement was demonstrated in several domains of sexual response, along with a decrease in sexual distress. Identifying underlying psychological factors that are contributing to HSDD can help to select the appropriate intervention, as shown in this table. The recommended approach for women with a history of abuse or trauma is referral for psychotherapy. Based on the pre-visit questionnaire results and your initial conversation with Jen, you take a comprehensive sexual history. She reports no comorbid medical conditions, medications, or current life stressors. When asked about past sexual abuse or trauma, Jen reveals that she experienced date rape during high school. She tells you in a shaky voice that she only recently revealed this event for the first time, when she shared with a close friend what occurred when she was 18. You see tears welling up in her eyes. You suspect that the sexual assault may be related to her lack of sexual desire, but you're not sure. How do you respond? You say, "Jen, I am so sorry this happened to you. I can only imagine the impact this sexual assault has had, and I am so glad you told me about it. Anybody who has experienced sexual assault would struggle, and I think it might be helpful to talk to a professional mental health professional who specializes in this area." You go on to say, "However, you also brought up your loss of desire as something you want to address. The sexual assault may likely be related, but I think you can tease out if it is related or separate with a therapist who is also an expert in treating sexual concerns. I'm going to give you the names of a few specialists that can address both issues." You ask her if she'd still like to go ahead with her well-woman exam today. She says she would, and you conduct the exam, noting in Jen's health record that all findings are normal. You provide referral information with a list of specialists and ask her to return in 3 months for a follow-up visit to make sure she is getting the care she needs and is doing better.